Welcome to the PTUB Pod, an educational podcast created by paediatric trainees in the Southwest.
Featuring reviews of journal articles and interviews with authors and specialists.
Please note, these are our own opinions and do not substitute professional medical advice.
Thanks for listening. Hello and welcome to the PTUB Pod. We've had a summer break and it's lovely to be back with you all. My name is Felicity Cooksey and I'm a paediatric trainee in the Severn Deanery. Today I'm very pleased to welcome Dr Marie Monaghan. She is a general paediatric consultant with a specialist interest in epilepsy based at Bristol Royal Hospital for Children. Marie has an impressive CV. She has experience of research and has also had experience working internationally with MSF. Today we're talking about idiopathic intracranial hypertension. Marie co-authored consensus recommendations for the assessment and management of idiopathic intracranial hypertension in children and young people, which was published in Archives. The lead author of the paper was Dr Sam Amin, and the link to the full article and reference can be found in our show notes. Thank you so much for joining me.
Oh, thanks for having me.
How are you?
Great. Yeah, it's really good.
Could you tell us a little bit more about yourself and your career journey?
Yeah, absolutely. So I was born in London. I moved to Canada when I was small, then to Dublin, and then back to London again. I stayed in London where I did my training, got into paediatric training in South London. I took a year out of Programme for Experience, initially working in Myanmar with Global Links volunteers. So that was my first taste of working abroad, being a paediatrician. Then I came back to the UK, continued registrar training in London, before then taking another year out of Programme for Experience to work with MSF, doing some projects in Iraq, one with the Yazidi population and then another in Mosul, and then another final project with MSF in Niger in Africa on a malnutrition project. So then finished that, came back to the UK and then immediately came over to Bristol on an interdeanery transfer where I've just kind of stayed since 2019. Yeah, so that's me in a nutshell.
It sounds like such a varied training program compared to a lot of people. And I know lots of people are really keen now to have those kind of out of program experiences. We're talking about IIH today, but I can't miss the opportunity to ask you about those experiences. Do you mind telling us a little bit more about those times being abroad?
Yeah, I mean, I recommend working abroad completely. I think it's eye-opening. I think it's also stimulating. If you're not quite sure what kind of paediatrician you want to be, you might find you have an interest that comes out by working abroad. Because before I went away to Myanmar, I thought I was interested in neonatal medicine. I came back thinking I'm a general paediatrician. And then when I went to MSF and worked in Iraq, seeing lots of genetic conditions and epilepsy, trying to help children who had intractable seizures, making a diagnosis of X-linked adrenoleukodystrophy, which somehow you can do with minimal testing. It was all really, sort of helped focus what I was interested in. I came back with an interest in doing epilepsy when I came back to the UK. I also think on a personal front, you get to see how a hospital functions. The actual mechanics of a hospital is sort of really visible in MSF. You see all the factors that keep it working really well. And also when it's not working, you can see what the effects are of one aspect not working well. And I think one final thing about working abroad is, especially with the project in Niger, when I was working with my partner and we were working in a French project, and our French, we have conversational French and we have medical conversational French, but I think we appreciated how difficult it is on a personal level to work in a second language. So as soon as I came back to the UK, anyone who I saw that I was working with who was speaking in their second language as a doctor, I had so much respect for them. But also, if it was their first few months, I had a lot of time of day because I could remember how excruciatingly awkward and painful and difficult and stressful that is. So I think it's really good on a personal level to do that as well. In terms of getting it done, it's about having the inspiration that you want to go and do something, trying to find someone who's done it and just go and talk to them. I'd say that's the first thing, and then planning it into your life. With the training programs, you need to give usually about 9 months' notice to say you'd like a year out Programme for Experience, but you can easily make it happen. I think the hardest thing is finding an idea and being inspired enough to sort of pursue that idea.
How did you find the transition of going from the UK to going abroad and then coming back to the UK, like those transition points? What was that like?
Interesting. Yeah, I think before working in Myanmar, I hadn't worked abroad in that sense. I'd done an elective partly in Brazil, partly in Australia, but I barely visited Asia really. I found that sort of confidence building experience quite difficult, but I was with company. What was really hard, actually, much harder than the first time of going out with Myanmar, you could adjust to that. What was really hard was coming back from the final MSF mission in the malnutrition project. So, on a personal level, seeing 1 to 4 children die every day for 3 months, the mortality rate was 10%. I think this hospital in Niger, if they didn't have that children's hospital, 100% of those children would have died. So it's sort of coming back from that sort of experience is quite difficult, to come back to sort of first world expectations of medicine. And I think one of the other things on a kind of personal level that really shocked me is you come away from a really low resource country back to Bristol, and I think one of my most vivid memories was going to a co-op and seeing that they had about 40 types of butter in a butter area, and just being a bit offended at how many types of drinks we had and how much a bottle of shampoo could cost. And I had a lot of money guilt, or privilege guilt, and I think that's maybe something we should all have a bit more of. And I do think out of sight is out of mind, so I know that all these world pressing issues are still happening, and it's kind of hard to balance that feeling when you know, how do you kind of live with that, the pressures in the world. And that was an adjustment.
Did you feel when you were away you had good support? Because it sounds like managing those mortality rates must have been so psychologically tough.
I think it's difficult. I think that mission is kind of notorious. It is really hard to be there, because if you are not in the Swan intensive the intensive care for nutrition, like the ward that was the highest acuity, if you're not there, more children will die. And if you're there, fewer children will die, but you have to also expect some children to not make it. In terms of support, I think you've got your MSF community, so you live in a residence. There's usually a few residences, and you'll have your meals with people. You all work side by side, so you've got your human resources, you've got your water sanitation person, your logistics, your field co for security, admin, finance. You're all kind of having day-to-day time, and MSF try really hard to support the psychology of everything. So they have these volleyball days on Sunday. They'll have a visiting psychologist who works with not just the visiting staff, but also the national staff, because burnout is a huge issue in these places. So I think they do try and consider it, but I think you've got to have done other missions before you'll be placed there, because I think it would just be really hard to manage. Kind of step up to seeing that, really.
Sure. Oh my gosh. I'm going to have to get you back on to talk just about those experiences. Because, that sounds like you've got lots of knowledge to share.
And we'll get Michael too, because he was my other half.
Brilliant.
Luckily together on that. So Michael works in paediatric A&E, and we both had been working with MSF, and we were placed on this mission together. And I think that was a helpful support in terms of speaking in French, but also the resilience you need to process what you're seeing. And I think we were both really fortunate.
So today we're going to be talking about IIH. So starting at the beginning, what is it? And why do you think IIH is an important topic?
Okay, so IIH, or Idiopathic Intracranial Hypertension, is exactly what it says on the tin. Essentially, it's when you have unknown cause, so idiopathic, intracranial, inside the head, hypertension meaning high pressure. What's really confusing about it is it's also been referred to by so many other names. So pseudotumor cerebri syndrome was a name that was created in 1904. And there's also been the name benign intracranial hypertension, which was used from 1955. So these are all synonyms. But one of the aspects of this Delphi study was to confirm the name that we should use, because there's still some controversy about that. One thing for sure, I think, among the neurology community is that we shouldn't really call it benign intracranial hypertension, because nothing that causes harm is benign. Headaches, therefore, not fun. And the potential loss of vision, permanent loss of vision, is a risk with IIH, so we shouldn't really go with that term anymore. Why is it important? I think it's going to be something as general paediatricians or people with neurology interests are going to see more and more, because the UK, people might know, has, I believe, the highest rate of childhood obesity in Europe. And we know that obesity is a risk factor for IIH. So there might be a kind of wave coming of IIH that we all need to be ready for. I could give you some numbers on the rates of IIH in the UK right now, but I think these are all going to sort of triple, quadruple in coming years. But essentially, approximately 1 per 100,000 children. So quite small numbers currently, but that's also children who've been diagnosed. So I think there's lots of variables there. In terms of the actual sort of hypertension, this was one of the aspects talked about in the paper, what qualifies as a high enough pressure. But essentially it's 28 centimetres or 280 millimetres of CSF pressure, or anything over 25 if someone is awake and not obese. Generally speaking, in paediatrics, we're not generally doing manometry on people who are awake, and we're not generally investigating for IAH in those who are not obese. So I would just keep the number 28 centimetres in your head, because that's probably easier. And then finally, going back to the idiopathic. So idiopathic means we have to have looked for other causes. So that's kind of how you get to idiopathic intracranial hypertension.
Thank you. Now, the most common symptom is headache, which is a very common presentation, and you mentioned obesity there. Are there, when we're kind of taking histories and completing examinations, when we're thinking about clues and what we're looking for, can you remind us of some of the red flags and what we should be looking out for?
Yeah, so I guess the most likely thing you'll hear in a history is headache. And generally these are headaches that are worse in the morning, on standing, on bending down, on the Valsalva manoeuvre. So, if they're on the toilet and things like that, that's something you would definitely expect. Visual loss is something that can be difficult to diagnose in non-verbal children. So if they had autism, or if they're younger children, that would be something that would be probably demonstrated in them bumping into things. Sometimes they might describe a clouding of the vision, and sometimes they might describe photopsia, with so flashing lights or dotted lights. They shouldn't really have nausea, vomiting or photophobia, because those would be more migraine symptoms. So there are some sort of teasing out to do. And then in terms of presenting signs, so sometimes what will happen is the child's being taken to the optician, and then the optician's done retinal photography and found papilledema. So that could be one of the first signs. And sometimes with IAH you can get a sixth nerve diplopia. So if they're complaining about a blurred or doubling of vision, that would be something that would make you think about that too. There are some other signs and symptoms, but essentially headache and visual loss would be the main two.
Sure. And other than obesity, are there any other key risk factors for developing IIH that we should be aware of?
So it's significantly more common in women or female patients. We don't know why that is particularly. There's lots of theories about the hormones that we have and how they affect our blood flow and CSF production, for example. But for sure, it's far more common in even girls, teenage girls. Obesity is a risk factor. So just remember that in paediatrics compared to adults, we don't use the raw BMI, we use the BMI centile. So it is important to use the RCPCH growth charts and look at the BMI centile being over the 95th centile for a diagnosis of obesity. That's really important because younger children, obviously, they might not have a high raw BMI number. In adults, so there's a risk factor if you have doxycycline, so people who are on antimalarials.
I hadn't realised that.
But I don't think in children we would see that very often used.
No.
Sleep apnea is an interesting one. That is fairly common in paediatrics, especially with obesity. And why that affects you is that it affects your CO2 levels. That can affect your blood flow, and they believe it changes how the blood flows through the brain, but also potentially how CSF pressure is affected from that. So just something to think about.
I think one of the issues that you've kind of come across in the paper is that there aren't any randomised controlled trials looking into kind of the management of IIH. And so as part of these consensus guidelines, you and the team completed a triple round Delphi study to help come up with recommendations. Mm-hmm. What is a Delphi study and how did you complete the process?
Okay, so a Delphi studies in general I think are becoming more popular because I think there's a growing appreciation that we want to provide equivalent, fair, standardised ethical care, but there isn't always the possibility of getting a good evidence base. There might not be literature out there on the exact questions that we'd like answered. And that might be for very real reasons, either not being powered because of rare conditions, or maybe ethical questions about the two options faced in some very significant situations. So a Delphi study is really something that's used when there's no clear, significant evidence base is available. And as we said, sometimes you can't do a randomised controlled trial. So if you were interested in acetazolamide for the use of IAH, would it be feasible to do an RCT for that in children in the paediatric population? Probably not that feasible, and probably going to be underpowered to really show what we wanted to show. So what Adelphi does instead is it gathers consensus opinion, expert opinion, and that means that a doctor practicing, for example, in a district general hospital will know that they're doing the same practice that the experts in the field would recommend. And that gives them not just the sort of guidance that they need, but also a way to defend the choices that they're making without having that evidence base to go to. In terms of what makes a good Adelphi study is to have more than one round so that you get initial responses. And if there's uncertainty, you can sort of make the questions more precise or actually just sort of really pin down the details if possible. So you want to have various rounds. You also might want to have reproducibility of responses. So you might, in other studies, you might change the wording slightly just to check that actually this is a consistent finding. And in some Delphis, they also do location checks because there might be institutional bias or sort of geographical bias that in one part of the country, this is exactly what they do. But actually, if you went to another region of the country, that might not be the standard practice. So you'd like your Delphi to really reflect expert opinion in all the relevant areas. And then in this particular Delphi, this was a 3-round Delphi, which actually had 2 rounds of questions for the experts in the field and 1 separate round just for ophthalmologists. So that was sort of more specific, to do with the papilledema and the management of that. And in this Delphi study, the survey respondents were basically sent to 114 email invitations were sent in round 1, and we had 54 responders who completed the survey. So that was a pretty good response rate for a national study. We had paediatric neurologists comprising 61%, general paediatricians 9%, neurosurgeons 9%, ophthalmologists 7%, neuroradiologists 4%, and a general paediatrician with a specialist interest in neurology 2%. So we had others as well, optometrist, community paediatrician, and a patient group representative. And then in round 2, there were 127 email invitations sent out and 65 people responded. So again, a fairly good response rate. And then in round 3, the ophthalmology specific round, we had 59 paediatric ophthalmologists involved. So we tried to get a good cross-section. And this Delphi essentially tried to address how we diagnose IAH, how we investigate and manage for it, and again, try to provide clinicians with recommendations on how to manage this condition in real life.
Great, thank you. So from the Delphi study, what was the conclusion about the diagnostic criteria? Do you mind just recapping that for us?
So there are 2 proposed diagnostic criteria options for IAH. One is the classical modified Dandy criteria. So what the Dandy criteria, which pre-existed, the Friedman criteria, in the Dandy criteria, you have to have symptoms of increased intracranial pressure. You have to have a lack of localizing neurological signs except for unilateral or bilateral sixth nerve palsies. We also need to have increased CSF opening pressure with a normal composition of the CSF. And we need to have normal brain imaging with no hydrocephalus and no other cause of raised ICP. This is different to the Friedman criteria, which was selected during the Delphi study. I also prefer the Friedman criteria because it gives options for a diagnosis even if you haven't got papilledema, and it also has options for probable IAH if not all the criteria are met, so it's a bit more flexible. And the criteria for Friedman's criteria for IAH are number 1, papilledema. You need to have a normal neurological examination except for these cranial nerve abnormalities. Neuroimaging needs to be essentially normal, but there are some exceptions where you can have neuroimaging consistent with IAH diagnosis. And you need to have a normal composition of the CSF. And then finally, they give the CSF values for children. So they say elevated lumbar puncture opening pressure of over 28 centimetres of CSF in children, or over 25 if the child is not sedated and not obese. And then what I was saying about the flexible aspect, so a diagnosis of IAH can still be made on the Friedman's criteria if there is an absence of papilledema, as long as there is an abducens nerve palsy, so sixth nerve palsy, and all of the other criteria are met. And also, IAH can still be diagnosed if the non-papilledema criteria are present, but in combination with at least 3 of the 4 neuroimaging criteria that are stated. And you can have a look at those in the paper. And finally, the Friedman criteria allows for a probable diagnosis if you have bilateral papilledema, even if the CSF pressure is not diagnostically elevated.
Yeah, that is really interesting. So just thinking it through, you've got someone you suspect has IAH, you've done the lumbar puncture and the pressure is greater than 28. Assume before doing the lumbar puncture we would have done neuroimaging. What other investigations will we be thinking about?
Okay, so I think what we're trying to say with the idiopathic is that there's no other cause behind their symptoms. So if you have got papilledema, generally speaking, that would be something that's caused by high pressure, but you want to investigate the papilledema properly. So the ophthalmologists are the best people to manage that. They can do what's called an OCT scan. So an OCT scan is a bit like an ultrasound for that retina, optical coherence tomography. And essentially that can look at mimics of papilledema to actually interrogate, is this papilledema that we're seeing on the photography, or is there some sort of buried drusen or other cause for that appearance? So investigate the vision. So in terms of blood tests that we might do to investigate the headache side of things, there are so many causes of headache. I'm sure electrolyte imbalances of pretty much any kind could cause headaches to happen. Some of the weirder things I found out included that if you have high vitamin A levels, that can cause a headache. Anecdotally, this was identified because apparently Eskimos knew not to eat polar bear livers, because not only would you have a severe crushing headache, but you could actually die, because that's how high the polar bear liver is in vitamin A. And I don't know if that's how they discovered that vitamin A causes headache, but it's certainly something to think about, because we know people are buying over-the-counter medications. There might be all sorts of reasons why they would be taking vitamin A. So that's something to think about. So just routine blood tests. And then when we do the CSF, we obviously want to look for other causes, such as, infectious causes. In terms of the autoimmune tests, I feel that as per the guidelines, that didn't really meet the threshold to do routinely, because you could imagine doing quite a lot of manometry and initial LPs for children who present with headache, but we wouldn't say routinely, please send off these, exhaustive autoimmune panels. So the indirect markers would be, white cell count or protein being elevated as sort of markers to perhaps do further samples. You might just want to have a good CSF safe sample so that you can do those tests.
Yeah. So once you've made a diagnosis, what are the next steps in management? You've mentioned some of the other investigations we do to confirm it actually is IIH.
Okay, so I think if you have made a diagnosis, then you want to manage the causes, the underlying reasons as much as possible. So if that's obesity, potentially as a contributing factor, you could try and refer to the appropriate specialist for that. If there's obstructive sleep apnea, you might want to refer to the respiratory team. So try and identify causes and treat those as you would. The management of the vision would be, again, managing these causes, but making sure the ophthalmology team are involved. Starting medication, we have in the guidelines gotten consensus, not through the Delphi method, but through the working group after discussions and clarification of the question, that acetazolamide would be their first line medical choice. And acetazolamide is one of the carbonic anhydrase inhibitors. So the idea is that the CSF overproduction can be sort of reined in with acetazolamide. We also have a separate table in the publication with a summary of the recommendations, and I'll try, if it's okay, to whistle through that.
Yes, please. Thank you.
So in the summary of recommendations from the paper, these are kind of aspects which all met consensus. So in terms of the timing of assessment, I think, just so you know, it's a kind of quick time frame to try and get a diagnosis within 2 weeks because of the effect of potential vision. We talked about treating underlying causes. So again, having all the growth metrics really recorded and BMI centiles recorded so you can plot how that's going. Making sure you've checked against the criteria, the Friedman's criteria. Sometimes we need to discuss those neuroimaging findings, again, part of the diagnostic aspect. So bring these patients to the neuroradiology meeting if you have that in your area. We have one every Wednesday in Bristol. There is the possibility of arranging an MDT meeting for the management of IIH, so you can build these MDT meetings, especially with the guidelines. We recommended neurologists being present, ophthalmologists being present, neuroradiologists at the very core, but you can expand that MDT to the general paediatrician, the community paediatrician, dietitian. Laboratory investigations, I think, things that should have been done at baseline just to make sure they've been done. So thyroid function, those electrolytes, including sodium, potassium, creatinine, urea, liver function, calcium, phosphate, magnesium. Glucose, I think that was an interesting one because with obesity, there's a potential of type 2 diabetes, so don't miss that. Vitamin D, checking full blood count because we know that unfortunately children with leukemia, for example, can have CSF involvement with their leukemia.
Oh, interesting.
But again, in the CSF white cell count, we would have seen that.
Yeah.
And now other things, so clotting, that isn't something we would say is a cause of headache, but if it's sort of a clinical concern, if there's bruising or other concerns, you would check that before you're doing it ULP. We've talked about ophthalmology assessments, we've talked about the values of the CSF pressure, the dietary management, the medical management I've said is the acetazolamide. And it's really important to be conscious of the fact that renal function can go off after acetazolamide, and that sometimes, actually quite often, these children can have depressed bicarbonate. So sometimes they need sodium bicarb supplementation. And in the guidelines, we recommended a threshold of 18 millimoles per litre. So if it's less than 18, you might want to think about adding in some bicarb as a supplement. The final aspect of management was that if you're sort of on good doses of acetazolamide and things aren't getting better with the weight being managed, you might want to ask the opinion of the neurosurgical team. We know that the neurosurgeons are able to do continuous CSF pressure monitoring if we do a short stay admission, for example, to find out actually what is the actual pattern of the CSF pressure. Children who are having recurrent LPs, that's not really sustainable. So the neurosurgeons have options for CSF pressure management. This can include a ventricular peritoneal shunt, for example. They used to do lumbar peritoneal shunts, but I think less so nowadays. And potentially for some suitable patients who have venous sinus stenosis. If you have venous sinus stenosis suggested, they can do venous sinus stenting. All of this is very expert, but the main thing to say is don't be afraid to approach the neurosurgeons.
Oh, thank you. I had a couple of questions about management. The first one was about done the lumbar puncture, we found out the pressure is high. Not everybody is familiar with doing therapeutic LPs. So if you've done the LP and you've seen it's high, in terms of managing that situation in the room when you're there and taking CSF off, do you mind just reminding everyone what pressures we should be aiming for in the context of doing a therapeutic LP?
So if there is a raised CSF pressure during manometry, over 28 centimetres of CSF, we recommend that this should be reduced down to 20 to 25 centimetres of CSF. And in other units, that would be 15 to 18 millimetres of mercury. So yeah, we do want it reduced down to a normal value. And that is to basically reduce some of the pressure, which we feel is the risk for papilledema and the potential loss of vision.
Oh, thank you. My other question about management related to pyramate. And I appreciate, I don't want to muddy the waters because I appreciate you've said acetazolamide is first line. In my experience, I've come across some people choosing to pyramate first line because it's in the context of children also and young people also having issues with weight management, and said that actually to pyramate as a side effect can help support weight loss effectively. And I just wondered what the guidelines and what thoughts were on using topiramate.
I think topiramate can be an excellent option for exactly that reason, because of the weight management. It has an appetite suppressant effect. The other benefit of topiramate is it is also sometimes used as an anti-migraine treatment option. Joint third, fourth line after your other preventers, prazosin, propranolol, flunarizine, you'd kind of then get down to topiramate potentially. The risk of topiramate is, and I don't know if you've seen this before, but you can get quite significant kidney impairment. And that's why actually with both acetazolamide and topiramate, they need to have routine renal function monitoring. I think because in adult populations they use acetazolamide as their first line, that may be where the consensus preference, the familiarity of using that came from. It may well be in the future that with more confidence in using topiramate that we do switch to that.
That's really helpful, thank you. In reading the paper, although recommendations are made, there were several areas where consensus was lacking. Could you tell us a bit more about this and how you were able to formulate recommendations when actually there is this lack of consensus?
Yeah, the lack of consensus areas were frustrating. Sometimes I think it could be put down to the wording of some questions. So, for example, should an LP opening pressure of over 28 centimetres be considered diagnostic for IIH? And this did not meet consensus, although 56% of people said yes. And I think it would be quite reasonable to have reservations about that, because you haven't contextualised the situation to say, have other criteria for IIH being met?
Yes, that makes sense.
How is the LP being done? Is this an awake child? So I think sometimes there's just ambiguity. Some of that was attempted to be resolved in the follow-up surveys, but still, I think it's difficult to pin people down to a yes/no when sometimes answers need to be more nuanced. I think that was one of the most common things. The other areas that we really struggled to get consensus on were the sort of more niche areas. So optic nerve sheath fenestration. From an ophthalmologist perspective, that might be something that in some areas is more practiced than others. We know it's hardly ever done in paediatric population. And some of the comments were that they opted for medical management or neurosurgical options in preference to that, although it still remains sort of emergency procedure where there's a pending threat to vision. Neurosurgical input into the neurosurgical options was certainly something that was a challenge for this Delphi study, because the actual participation of the neurosurgical cohort was quite low, and we've made recommendations in this study that perhaps that could be something that could be explored more, but might need international input, because you want to capture the paediatric neurosurgical IAH field.
Yeah. Thank you. What are the long-term outcomes for children and young people with IIH?
This is one of those longitudinal studies that just doesn't exist right now. So we don't have a UK registry of IAH. We don't have a paediatric registry. We don't follow these patients up from that setting. I think it would be really useful to do from a visual perspective, but also on a quality of life. If you have had headache pretty much every day for such a long time, how does that affect your educational outcomes? How does that work out for your day-to-day? So I think that would be really helpful. And I know that business intelligence, if you go to the IT teams in hospital, if the medical coding has been performed accurately, you can quite quickly pick out IAH as a diagnosis. And it would probably be relatively easy to do that on a local level, if not national. There's so many studies that could be done like that.
That'd be really interesting for the future. Yeah. And we've spoken about so much today in terms of IAH. What are the key take-home messages, kind of to summarise, to send people away with?
I think you can only diagnose what you can think of or consider. So I think if you're seeing children with headaches that just don't quite fit other types of headache, and they're really struggling, just for a second stop and think, could this be IAH? And I think having that awareness of it as a condition, and having an awareness that we should see more of it, we probably underdiagnose it. I think if you have that first instinct to think of it, that's half the battle. Because otherwise, who will do an LP for headache? Not many people probably. So if you think about it, that would be really helpful. And then, look at our lovely publication.
Brilliant. Yeah, it's packed full of information. Thank you. And many of our listeners are paediatric trainees. If you could give them one piece of general advice, what would it be?
Oh, wow. That's a really big question. One piece of general advice, I think find role models in your life. I think career role models, but also work-life, inspirational role models. And try and enjoy what you do, because we're always worried about the next exam or the next training barrier or permissions or job interviews, and it all kind of flies by. So I think don't sort of just see up to the next exam. Try and have a happy idea of what you would like to be doing in 5 years' time, and try and, like a holiday, you should always have a holiday on the horizon. When you come back from one holiday, try and get the next one. So I think have something that you're looking forward to doing professionally and in your personal life.
And my final question, which we ask all of our guests, do you have a book recommendation? And it doesn't need to be medical.
Yes. Well, actually, I have two recommendations. I used to read novels and literature like a lot more as a teenager, and I've kind of gotten to that busy phase of life where I tend to switch to Audible or podcast more. And my favourite podcast would probably be The Moral Maze on Radio 4.
Okay.
It's just sort of one of those frequent things that they do. And they have really interesting topics. Really, the kind of fascinating topics that you love hearing people debate on a really high level.
And you say The Moral Maze?
The Moral Maze.
Oh,
yeah, it's really,
I'll have a listen.
And then I also really like everything by Peter Singer. So he was a proponent of effective altruism. Yeah. And he's got a book of essays right now on topical moral issues, and I'm really not that into ethics, but I really love a good debate. Yeah. And I love hearing the different arguments, because you have to be persuaded.
Yeah. Oh, that's really interesting. Thank you. Thank you so much for joining me today and for being such a fountain of knowledge. And I hope everyone listening enjoyed this episode. Please do let us know your feedback.